we get these slides up and running. There we go. So yeah, we're going to talk today about the treatment of Lennox-Gastaut syndrome and really some updates. And the good news is I have a lot of slides, which means that there's a lot to talk about, which is very exciting. I'll just start with some disclosures. There's a variety of different companies, most of them, as kind of Tracy alluded to, within the genetics arena that I work with for development of therapies. So today I want to cover several things. I'm going to start out the talk by reviewing data for anti-seizure medications that already have indications for Lennox-Gastaut. So we're going to talk about what we know with really good evidence. And then after that, I'll touch on some medicines that are commonly used in Lennox-Gastaut that have some evidence, but not as good as the first level that I'm going to show. So this is kind of things we think we know. Then I'll start to get into some exciting new stuff, which are the new medications that are being developed as a treatment for Lennox-Gastaut. I'll also cover some non-pharmacologic treatments because obviously there's other ways to treat epilepsy than just with medications. So we'll talk about things that sometimes we probably don't talk enough about. And then finally, and I kind of caught the end of Dr. Worrell's talk, we'll talk about some of the new treatments that are specific to rare epilepsies of genetic origin, because I think they really kind of open the door to show you what the future may really hold when you very well understand the reason for your epilepsy. So let's start with the drugs that already have approval for Lennox-Gastaut. And as I go through these next slides, there's going to be a couple things I just want to kind of get us all on the same page. These are drugs that have FDA indications for the treatment of Lennox-Gastaut. And to get an FDA indication, you generally will have to have some very strong evidence, and that evidence is almost always based off of what we call phase 3 drug trials. And these are trials that are double-blinded and placebo-controlled, and those are two very important concepts. Double-blinding means it's a trial, whereas the doctor, I don't know if you're on the actual drug or you're on a placebo. And you also do not know if you're on the drug or on the placebo, and that eliminates much of the bias of the treatment. And then placebo-controlled is important because you have to have an arm of a study that's not treated, so you can truly see the difference between what the treatment has provided to what would have happened had they not been on treatment. So those are the important concepts to think of as we go forward. So the first medicine is Lumotrigine. You may also know it as Lamictal. And it underwent a double-blind placebo-controlled trial that began with a baseline period. Almost all of these trials will have a baseline, usually about 4 weeks in duration, where the patient entering the trial makes no changes to their therapy. And so over that time, we just count seizures, and it gives us a pretty good understanding of what the daily frequency of seizures is in that person before they enter the part of the trial where they receive treatment. So after the baseline, they go through a 6-week titration in this trial. Then they were allowed to be stable for a time and then could increase the medication further if needed. This study was specifically looking at tonic, clonic, and drop seizures. You'll notice throughout these approved drugs, almost all of them have either chosen to look at tonic, clonic, or drop seizures as their primary outcome. So what did they find? So with Lumotrigine, they saw in the placebo group, there was about a 9% decrease in seizures versus a 32% decrease in the treatment group. So that was statistically significant, which shows that there is some reduction of seizures utilizing Lumotrigine. You can see in the different graphs we have there on the side, they look at what are called responder rates. So responder rates are the percentage of people who have more than 50% reduction. And as you can see there for drop seizures, 37% of the participants had more than 50% reduction in their drop seizures versus 22% in the placebo group, whereas the tonic-clonic seizures, it was a 43% reduction, or 43% of the participants had 50% reduction versus 20%. I'll just point out, because people often ask, why does the placebo group get better? There's several reasons. One is just the placebo effect, the idea that you think you may be getting an active treatment often will have some impact on how you count seizures. Also, what happens in trials is they're very regulated by protocol. So everything has to be done in a very particular manner. Medicines have to be given, every day as they're supposed to be given. And as a result, people are actually often very much more compliant during research trials, which means that their seizures often do get better, even if they're on the placebo. This particular study did not report seizure freedom. I think that's always an important thing we want to know, because isn't that the ultimate goal of any treatment? As far as adverse effects, the adverse effects were actually, the profile is very good for Lumotrigine. Viral illnesses were slightly more reported in the treatment group versus the placebo group, but nothing really specific of concern. And an added benefit of Lumotrigine is that it does have some mood stabilizing properties, which can be of benefit in LGS. Then our next medicine is Felbamate. This medication, very similar study, double-blinded, baseline, and then treatment, looked at tonic, clonic, and drop seizures by both parental report and in this particular study also video EEG. So what they saw was a 44% reduction in drop attacks versus 7% in the placebo group. If you looked at tonic, clonic seizures, there was a 40% reduction versus 12% in the placebo group. And then if you took all other seizures, about a 26% reduction versus 5%. Medication has a few more side effects. Anorexia is more common, sleepiness, as you see with many anti-seizure drugs, and vomiting was more commonly encountered. The next drug is Topiramate. You may know it by Topamax, as it was its brand name. This trial included both children and adults, titrating up to about 6 milligrams per kilogram. I just point that out because the dosing of Topiramate can range anywhere from around 5 per kilo up to some people have gone as high as 15 to 25 per kilo. So this particular study was at the low end of treatment dosing. And for the outcome here, drop attacks decreased only by 15% versus 5% in the placebo group. This was statistically significant, so there is a difference. It does something, but maybe not as profound as the medicines we've shown so far. They did mention seizure freedom, though, in their study and found that 11% of the patients during the treatment phase were free of drop attacks. So, that's a decent percent of participants. And finally, the placebo versus treatment arm for the responder rate, 33% had greater than a 50% reduction in seizures versus 8% in the placebo group. Topiramate has, again, kind of common side effects we encounter, somnolence or sleepiness and dizziness, behavior change in some. Importantly, Topiramate can depress appetite in some people, so there can be loss of appetite and weight loss in some cases. One of the more recent medicines was rufinamide. Rufinamide is also called Banzel. This study was from age 4 to age 30 years, so both children and adults in this study as well. And again, looked at primarily drop attacks. They defined drop attacks as tonic, atonic seizures, which are the two most common seizures that do result in drop. And a pretty good response here, a 43% decrease in the tonic, atonic seizures versus a 1.4% increase in those that took the placebo. As far as seizure freedom, they only reported 4% seizure free versus 3% in the placebo group, so that was really not a statistically significant difference. And then the overall total seizure reduction was about a third, or 33% reduction on treatment versus 12% in the placebo. Then clobazam, or Onfi, is another medicine which has an indication. This trial was also in children and adults with LGS, but included 3 different treatment arms. So there was a low dose group, a kind of moderate dose group of 0.5 milligrams per kilo, and then what was considered the high dose group, which was 1 milligram per kilogram per day. And in this study, drop seizures being the primary target, you see probably one of the best responses that we see with medications, in that the high dose group had a 68% reduction in drop attacks versus a 12% reduction in the placebo. And even the 2 lower dose groups had pretty significant responses at 41 and 49% versus the placebo group. So actually very encouraging. What I think is also encouraging with clobazam is if you look at the seizure freedom, almost 1 in 4 patients that were in the trial reported a 100% or seizure freedom in the setting of the high dose group. So, that's a very encouraging response, especially when you're dealing with such a difficult to treat epilepsy syndrome. The newest kid on the block in the LGS treatment for approval was Cannabidiol as Epidiolex. I'm going to show you more slides on this just because this is the newest approved medication. There were 2 studies for Cannabidiol and LGS. The first one had a 4-week baseline with a 14-week period of treatment with the drug, included both children and adults up to age 55 with LGS. And the requirement was that they had greater than 2 drop seizures per week during a 4-week baseline. And drop seizures were characterized as any seizure that would result in a fall, specifically atonic, tonic, and tonic-clonic type seizures. That's kind of an important differentiation, at least when you think about the other drugs, because now they've taken tonic-clonic, which are often grouped in the convulsive seizure category, and put them into the drop category. So it includes all 3 types. In the first study, the treatment was 20 milligram per kilogram of Epidiolex, given divided twice daily, or placebo. And parents kept track of the seizures on a daily basis, utilizing a seizure diary. So the primary outcome of what they were looking at primarily was the percent reduction in monthly drop seizures from the baseline to the treatment period. They looked at some other secondary outcomes, things like the 50% responder rate, as we talked about in other slides, total and subtype seizure reduction, and something called the Caregiver Global Impression of Change. That's a scale where they try to kind of encapsulate what is the overall feeling for improvement of the patient in the trial versus their baseline, so that it's an attempt to count something more than just seizures. Are they better from a behavioral standpoint or a sleep standpoint or some of their other comorbidities? So what did they find? The first trial had 171 patients in it. Their average age was 15, previously failing anywhere from 0 to 28 other treatments, with most people on about 3 drugs and an average of 74 drop seizures per month. And the primary endpoint was statistically significant, so a 44% reduction in drop seizures for this study versus 22% for the placebo. So that's a great outcome. Obviously, have shown some reduction in seizures. It's a little dampened by the fact that the placebo rate in these trials was so high, which was not surprising. There's a lot of excitement around the use of CBD for epilepsy, so even people in the placebo group likely have, some amount of bias knowing they were in the trial, which is why the placebo arm probably has a bit of a higher response than you saw with some of those other drugs. As far as the 50% responder rate, 44% of the patients on CBD met that criteria versus only 24% in the placebo group. And the overall total seizure reduction was about 41% versus 14%. Seizure freedom was reported, and so 6% reported freedom of all drop attacks during the treatment phase versus none of the patients who took placebo. And then finally, when you look at the Caregiver Global Impression of Change, 58% in the CBD group felt that there was improvement in that scale versus only 34% in the placebo. Side effects of cannabidiol are similar to what we see with other drugs. So you're going to see things like sleepiness and diarrhea and decreased appetite and vomiting. Those things can occur more frequently. There are a few important side effects that people need to be aware of. One is with the sleepiness, if you were on clobazam, that can be the cause of the sleepiness. In the setting of Epidiolex and clobazam, clobazam gets broken down into another medication called desmethylclobazam. And that level can increase by about 5 times when you take Epidiolex. So it's important, if you are taking these medicines together and you're seeing increasing sleepiness in your loved one, you want to consider, if you're on clobazam, possibly having that dose reduced. It's also important for your doctor to understand that they need, if they want to check a level to prove that that is the case, they need to check a desmethylclobazam level, not a clobazam level, because that is, the clobazam doesn't elevate, it's the active metabolite. The other thing it's important to know is that you can get elevated liver function testing, so your liver enzymes can elevate when taking Epidiolex. This occurs anywhere from about 5% to 25% of patients that take the drug, depending on which of the trials you look at. It occurs most frequently in people who are also taking valproic acid or Depakote. So it doesn't mean you can't take the two medicines together. You absolutely can. It's just something you need to be aware of, which is why periodic liver function testing would be looked at by your doctor. Signs of elevated liver enzymes are things like sleepiness, loss of appetite, vomiting, obviously jaundice or a yellow discoloration is definitely a sign. Abdominal pain is also another thing to consider. So any of those symptoms arise, it's important to think about checking liver enzymes. So then there was a second study of cannabidiol and Lennox-Gastaut syndrome, and the only difference in this study and the first one is that now they use different doses. So in the first study, it was only 20 milligram per kilogram per day versus a placebo, and now in this study, they used a 20 milligram per kilogram group, but also a 10 milligram per kilogram group, and then placebo. Otherwise, the trial was very similarly done. And so what they found, and what is important here, is that the group that was treated with a higher dose, the 20 milligram per kilo, had about a 42% reduction in drop seizures versus a 37% reduction in the 10 milligram per kilogram group versus 17% for the placebo. So what we can take from this is that both 10 and 20 milligram per kilo are effective doses at reducing drop seizures, and frankly, the two doses are not that different as far as how well they work. Which is why the ultimate indication for the drug is to start the drug and titrate to a goal dose of 10 milligram per kilogram per day. And if necessary to get better seizure control and the drug is otherwise tolerated, you can push the level up higher, now up to 25 milligrams per kilogram per day, to see if you get better effect. But you always start towards the lower end because we know it to be just as effective. This is just another look at 50% and 75% reduction. So I'll just point out that 25% of the patients in the study that took the high dose did have a 75% or greater reduction. So some people respond very well to this drug, which is why it is one of our choices that we certainly consider. Importantly to know also from the study, what we learned is that side effects are more common the higher the dose, which is not unexpected. But the higher you increase the dosing, the more likely you are going to see side effects. This was especially true for the elevated liver enzymes that we discussed a little bit earlier. In the tuberous sclerosis study of cannabidiol, they went up to 50 milligrams per kilogram per day. And about 25% of people had elevated liver enzyme in that study, which was the highest number in all of the studies they did. So there does seem to be some higher risk as you go to higher doses. The important thing I think I'll also mention about that is that if you have elevated liver enzyme on this treatment, it almost always can get better very easily. You can decrease the dosing of valproate if you happen to be on valproate, and often the levels come down within a few weeks. You could also just reduce the dosing of Epidiolex, and the levels seem to go down. And we even saw in the open label versions of the study that if we did nothing, that sometimes the levels would come down on their own. So it appears to be a transient problem for most people if you make some small changes to therapy. So speaking of the open label data, I will talk about that in the next couple slides. And this stuff is important because I'm sure you've all experienced, you take a drug, you start a new drug, and things are a little bit better for a little while, and then you kind of go back to the seizure frequency that you were at before over time, kind of as if you've lost the efficacy of the drug. And honestly, that's the nature of intractable epilepsies in general, that we see that initial improvement and then unfortunately get back to the same pattern. But it's always important to look at long-term data of drugs to get an idea of, is the efficacy generally sustained over time, or do you lose it? So in the long-term data from the LGS trials, what we basically see is the overall reduction that was experienced largely stays the same. This is a few years, a little bit over a year's worth of data here. We've now got data up to over 3 to 4 years. And the responses seem to be about the same. Understand that this is open label data, which means that all the patients are on Epidiolex, they know they're on Epidiolex, and that there are not rules limiting changes of other medications. So the fact that the seizure control stays the same may very well be because the medicine Epidiolex has continued to work just the same over time. But there's also the possibility that other meds and treatment things are being changed during this time, which can also affect that number to some degree. But this is just another way to look at that open label extension data. You can also look at retention rates, and retention rates are the number of people that remain in the trial, with the idea being that you might drop out of the trial if the drug wasn't working or if you're having significant side effects. And as you can see, the retention rates at 3 years are about 65%. So over half the patients, well over half the patients, remain in the trial, suggesting it has continued efficacy. So I've included a slide in here that just kind of tries to bring all of that together. So these are all the medications that have an indication and their overall reduction, their responder rate, and if reported, their seizure-free rate. So you can kind of compare the different drugs to each other. And so now the next section are drugs that are, approved drugs for epilepsy. They are not specific to Lennox-Gastaut. They do not have a specific indication for Lennox-Gastaut, but you will commonly encounter them. And as I say here, while everything's not meant to be, everything is worth a try. Everything is fair game in this syndrome to be considered as treatment. And so we'll talk about what data we have for them. So valproate, is very commonly used for the treatment of LGS, but it has never been through a phase 3 trial to, prove it works. So it's really expert consensus and a lot of experience with it that, we know it is a useful drug. There's a variety of different studies. These studies are different than the ones we talked about before because these are all going to be open label. Any patient knows they're on the treatment. These are mostly retrospective. So many of them are retrospective, meaning we kind of look back in charts and see how what they've reported. And so that comes with some bias. So the data is not as good, but it is still good data. So here we have 55% in this small study reported at least a 50% reduction in their seizures. The good thing about valproate is it has a very wide spectrum of seizures that it covers. So it covers drop attacks, myoclonic seizures, atypical absence seizures. It also, like Lumotrigine, has a secondary benefit that it has some mood stabilizing properties to it. Zonisamide is commonly used in this trial. They reported 47% of the participants had a greater than 50% reduction, and about 5% were seizure-free. Levetiracetam, which is also known as Keppra, showed a 58% reduction, or 58% of patients had a greater than 50% reduction, and they actually reported 27% were seizure-free in this particular trial that I cited. And then lacosamide, which is Vimpat, has had a few studies. I think what's important to point out here is that definitely some people have seizure reduction. As you can see, about a third to 50% report a greater than 50% reduction. But on the other hand, about 20% of people actually report worsening of seizures with lacosamide. So it is possible that some people get worse seizures on these medications. And that's actually true for several other medications too. This is a recent algorithm for the thought process of treating people. And this study divided things into tiers. And as you can see, the tier 1 is some of the more commonly used medicines that have LGS indications. They put Felvital down at tier 3. I think probably in the adult world, that's where it ends up. In the pediatric world, we use it much more commonly. So I would have moved it up. Some of the other newer drugs like Perampanel, which is Fycompa, is there in tier 2. And then you'll see at the box in the bottom, they list some medicines that can certainly be used in LGS, but there are potential risks that they could exacerbate some seizures. So medicines like carbamazepine and oxcarbazepine and phenytoin are great for focal onset or partial onset seizures, but they can aggravate generalized seizure types in some patients. So things like tonic seizures and drop attacks could potentially get worse. So now we're going to get into the exciting new stuff that we can expect to maybe see in the coming years for the treatment of LGS. And so the first will be fenfluramine. And fenfluramine is a drug that was part of a diet pill called Fen-Phen many years ago that some people may recall, that was ultimately taken off the market. So Fen-Phen had fenfluramine in it and another medicine called phentermine. And it was taken off the market because while it did cause weight loss, it also caused abnormalities in the heart. So the heart valves got thickening to them. They also developed something called pulmonary arterial hypertension. And so the medicine was taken off the market. And then many years later, some folks in Belgium thought it a good idea to use fenfluramine to try to treat children with Dravet syndrome. And they saw remarkable improvements in seizures. And thus began kind of investigations to see how fenfluramine would work as a seizure drug. So there has been a trial in Dravet syndrome, and this drug has been approved for Dravet syndrome just this summer. But they also followed that with a trial in Lennox-Gastaut syndrome. And so that data has also been reported. So it started with an open label study. So again, this is a small study where everyone knows they're getting fenfluramine just to kind of see is there a response. In this case, they looked at 2 doses of fenfluramine, and they had reported a 53% reduction in convulsive seizures, with a quarter of the patients reporting 75% or greater reduction and 60% reporting 50% or greater reduction. So, you know, a really nice response, which was actually similar in level to what we saw in patients with Dravet, which is why they kind of moved ahead with the investigation. So this double-blinded trial, again, had a 4-week baseline and then a treatment phase. And they looked at drop seizures specifically over a 28-day period at the baseline, then compared to treatment. And what they found was statistically significant. So the median reduction of drop seizures was about 26% in the high-dose group of fenfluramine versus an 8% in the placebo group. So statistically significant, not quite as high as the open label data suggested it was going to be, but it definitely works. The low dose group did not have a significant difference from placebo. So it does appear that the higher dose is necessary. As far as the 50% responder rate, 25% of the patients met that criteria versus 10%. And then there was not quite a statistically significant difference in the caregiver global impression of change between the treatment and placebo. As far as adverse effects, the adverse effects that we found in fenfluramine are what we would expect. So decreased appetite does occur. Rarely is it associated with decreased weight, though, so that's a good thing. Somnolence, fatigue, typical things we see with drugs that work on the brain for seizures. Importantly, there have been no cases of valvular heart disease or pulmonary arterial hypertension. So those main adverse effects that ultimately got the drug withdrawn from the market many years ago have not occurred in either the LGS trial or the Dravet trial. And this is hundreds of patients and thousands of echocardiograms. So that piece is very reassuring. So perampanel, which is Fycompa, is also looking at LGS as a potential indication. Like fenfluramine, perampanel has a mechanism of action that's different from many of the other traditional anti-epileptic drugs or anti-seizure medications. So this works on a receptor called an AMPA receptor. This trial is still ongoing and collecting data, and so there are no results available from this particular trial as to how effective it is, but there are some prospective open label and retrospective trials to look at data. This first one was a small study of just 13 children, but showed a 69% responder rate. So 69% of the patients reporting greater than 50% reduction. Adverse effects are a little more common with this drug. So agitation and fatigue may be more common. And obviously, some of those things can already be problems in LGS, so you definitely want to keep that in mind. This open label retrospective study, which is a little bit larger with 62 adults, also showed a responder rate in the 60s So 66%, with 17% of the patients having more than 90% reduction. So I think that's pretty encouraging. I use perampanel a decent amount in LGS, especially I think it's used for photonic type seizures. So it's definitely a choice to consider. Another new medicine is one called soticlestat, or you may see it listed as OV or TAC-935. And this drug is also a drug with a novel way that it works. And so it works on an enzyme that converts cholesterol in the brain to a different type of cholesterol that stimulates NMDA receptors. And so the way this works is this cholesterol stimulates NMDA, and the NMDA receptors are receptors that increase glutamate, and glutamate is an excitatory neurotransmitter. And so basically, glutamate, just think of it as it kind of represents increased electricity, and you see that in seizures. And what happens is it's a cycle. And the more seizures you have, the more stimulation you have, the more NMDA, the more glutamate. It's just a vicious cycle. And so the idea here is that if they can decrease the amount of this particular cholesterol that activates NMDA, then that they could in turn decrease the seizures. So there's been there's an open label. There was a randomized double-blinded study, very small, early study, just to get a sense. Using 18 adults. And the important thing about this study is they did the randomized portion of it, and then the people who appeared to respond pretty well went on into an open label portion and continued to use the drug. And so when you look at these results where the median seizure reduction was 84 and 90%, that's a very high seizure reduction, understand that these patients were the ones that responded in the first portion. So you've basically taken a group, you figured out which people did well with the medicine, and those are the ones you continue to look at. So you've now biased the information towards the good responders, but that's really all this was intended to do, was to show that the drug has the potential to reduce seizures. Interestingly, what they found is that if they could show that cholesterol type that they were trying to reduce was in fact reduced, those people did very well, whereas those people that took the medicine that did not get a reduction in the cholesterol did not seem to have a seizure reduction. So that really proves the kind of the concept that this reduction in cholesterol does seem to do something. They did note an increase in seizures in patients that were taking perampanel. And so when they went on to the next phase 3 trials that I'm going to talk about, perampanel was excluded from those trials. So they've recently completed a randomized double-blinded and placebo-controlled trial in Lennox-Gastaut and Dravet syndrome, and that data just came out a couple weeks ago. And so for the Dravet patients, they were looking at convulsive seizure types, and for the LGS patients, they were looking at drop seizures. All of these patients were in the same study together. So when you take all of the data together, what they saw was there was a 28% decrease in seizures, versus a 3% increase in seizures in the placebo group. So basically a 30% difference, which was statistically significant. Very exciting, means we have yet another medication that seems to help. Unfortunately, when you break the data into pieces and look at the Lennox-Gastaut patients and the Dravet patients, what you see is that this overall decrease was largely driven by the Dravet syndrome patients. So the LGS data showed a 19% decrease in drop seizures versus a 2% in the placebo group, which did not reach statistical significance. And the 50% responder rate was nearly the same between the two groups. So unfortunately, this data, at least in its first pass, did not seem to show quite the response that we had hoped for in LGS, but they're not finished looking at the data completely. So, I'm still hopeful they may find something in there that provides us hope for this therapy being useful in LGS. There's another drug called Topiramate, which is currently undergoing study, just an early phase 1 study in patients. There are no results published for this drug, but it is, again, a novel new drug with a slightly different mechanism of action. It has been looked at in focal seizures in adults and shown some efficacy in one study, though another study did not find the same response. Basically the focal seizures, maybe there's something there, but not nearly what we would hope to see. And so it kind of turned the attention now to kind of different seizure types, maybe some of the generalized, more diffuse seizure types of Lennox-Gastaut, and we'll see how it works. So in the next section, I'll go over some non-pharmacologic treatments for LGS that we should all consider. And the first being dietary therapy. And I'm just going to focus on the ketogenic diet. There's more than one diet therapy, of course. There's ketogenic diet, there's modified Atkins, there's a low glycemic index diet. But most of the data you find often refers to ketogenic diet, which is a high-fat, low-carbohydrate diet with adequate amounts of protein. Eric Kossoff and Don Shields published this study in epilepsy of a larger group of patients with LGS treated with a diet. And as you can see, about 50% of people have a 50% reduction, with almost a quarter of patients having a 90% reduction in seizures. So the diet can be very effective at treating some of the seizures of LGS. It does come with side effects, as do all treatments. Constipation, you're at higher risk for kidney stones. Obviously, you're on a high-fat diet, so elevated cholesterol can be something to consider. The vagal nerve stimulator, commonly used, approved in 1997 for partial onset seizures, but frankly, probably has efficacy for multiple other seizure types. The downside is that it's a surgery, but it's often a day surgery. You're in and out the same day. Adverse effects are fairly limited. Some people get a little discomfort in the neck or some hoarseness or cough that usually we can fix by just changing some of the settings. As you see down there at the bottom of the slide, a variety of different studies have looked at the vagal nerve stimulator and reported a wide range of seizure reduction, anywhere from like 25% to some of these have over 70% reduction. You have to be careful with these studies because they're basically open label. Everyone has a VNS. They know they have a VNS. The settings are different for all of these studies. So, which settings of a VNS really work best is not necessarily clear. Multiple people suggest that tonic seizures and atonic seizures respond best, which I would agree with. I think I see that as well. But a viable option to consider for treatment that's non-medicine. Epilepsy surgeries like corpus callosotomy are also great options, specifically when treating drop attacks like atonic type seizures. The corpus callosum is that bundle of fibers that connects the left and the right hemisphere together. And in a corpus callosotomy, basically what you're doing is you're disconnecting, or you're cutting those fibers in half so that you disconnect the right and the left communication. And the idea here is not necessarily to always render complete seizure freedom, but instead to stop the seizure from spreading side to side, resulting in the fall and the injury. And it can be very, very efficacious. Now, the good thing about callosotomies is that in the past, this has been a very large procedure, usually doing a craniotomy where you take the front part of the skull off so that you can visualize the fibers between the hemispheres, and you cut them in half. We have several less invasive approaches now. So corpus callosotomies have been done successfully with laser ablation, as I show in the pictures across the bottom. And you can also do it endoscopically. So using an endoscope instead of doing a large craniotomy, you can make a small, about 1 centimeter or so incision at the top of the head and put the endoscope in and be able to do the same procedure with a much smaller incision and a much faster recovery. So those are, great potential options. There's a good meta-analysis out there where they've taken lots of studies that have looked at VNS and callosotomies and kind of combined them together to get an overall feel for the response. This particular study included almost 350 patients with LGS that had undergone one of those treatments. And basically what they found is that for atonic type seizures, callosotomies are generally more effective. As you can see there in all the studies they kind of looked at, there was an average of 70% of patients had a greater than 75% reduction versus only 26% of those that had a VNS. Again, for atonic type seizures. When you look at the rest of the seizure types, the reduction in seizures were pretty similar. There's some limitations to studies like this because they're pooling data from multiple different studies. Not all of them are done the same way. They have different approaches to how the data was collected, how maybe the VNS was used, how it was titrated, how long the patients were followed up. But still, it gives you a kind of a good overview of comparing of the two. Deep brain stimulation is also something that is increasingly being thought about for LGS. This study from Velasco's group looked at 13 patients in which they used a deep brain stimulator. So this is a device that basically is a stimulating electrode that's placed into the brain, down into the middle part of the brain. It's called the thalamus. And there are different little nuclei down in there that control electricity. And we put the stimulator directly into those nuclei and stimulate it continuously throughout the day to kind of try to regulate the electricity, if you will. And what they saw is, some pretty good seizure reductions. You see there, they had some patients that reported complete seizure control after this procedure. Overall, it looks like the convulsive seizures, like the tonic-clonic seizures, were better controlled than people that had primarily absence seizures. But again, another potential non-pharmacologic therapy. And then epilepsy surgery. I think Dr. Worrell mentioned this kind of towards the end of her talk, that there are some patients with LGS who actually have an abnormality of the brain that may be very focal. So maybe, a part of the brain is formed differently, or maybe even a whole side of the brain was formed differently, but they then present with Lennox-Gastaut as their syndrome. And in some of those patients, if the area can be defined and you can completely remove it with surgery, seizure control can be significant. So in these trials of use of epilepsy surgery and appropriately chosen candidates, you've got nearly 60% seizure free, which is an exceptional outcome for this condition. But again, it takes, it's a very specific patient. Not every patient is going to have that underlying focal etiology and be a candidate. So now in the last section, I just want to get to treatments that are kind of coming up that are for conditions that may present as Lennox-Gastaut. So this is getting back to the stuff we were talking about, genetics. This is why it's important, if you don't have an etaology, that you want to find out if you have one, because there are some new treatments specific to genetic conditions that you may be eligible for. So the first is ganaxolone. Ganaxolone is a new drug that binds to GABA receptors and has been studied in CDKL5 encephalopathy syndrome. I'll skip in here and just go to the phase 3 results that they just released like last week. And so in this trial of children and young adults with CDKL5, they saw a 32% reduction in major motor seizures, which are basically convulsive seizures, grand mal, tonic-clonic type seizures, versus 4% in the placebo group. So a statistically significant improvement with fairly good adverse effect profile, with sleepiness the most commonly reported. So this is a new treatment for a person who might have CDKL5 who would meet they may meet the criteria for Lennox-Gastaut. So it's important to know if you would have something like this. Even more important was what is coming up in the future here, which is there are going to be disorders where there are precision therapies precise to the genetic cause of the epilepsy. And so in the last slides, I'm just going to talk about SCN1A, which is the cause for the majority of patients that have Dravet syndrome. So there is a treatment called Antisense Oligonucleotide therapy. And basically the way this works is in Dravet syndrome, we all have 2 copies of SCN1A. And what happens is people with Dravet syndrome, one of their copies of SCN1A has an error in it and it doesn't work. And as a result, they only have about 50% of the sodium protein they need. And then they present with Dravet. Well, all of the good copies and the bad copies of SCN1A have portions of genetic material that basically tell the body when to make more of it. And so the idea here is that if you could target those pieces of information and tell the body to take the good versions of SCN1A and just make more good SCN1A, you could actually make up for the bad SCN1A that's not being made. And so what they do is they take an antisense oligonucleotide, which is basically a piece of genetic material called RNA, and we give the material through a spinal tap. That material then gets taken up and binds to the messenger RNA and stops that area from working, and then allows production of more good copies. And so this is my incredibly easy explanation. So you have a good and a bad copy, and they all have these things called decay exons, which means when they have a decay exon, it gets thrown away. And so in regular world for them, the ones that have decay exons go away, so only the other ones come through, and you get about 50% of good stuff and 50% of bad stuff. When you use an antisense oligonucleotide, you basically bind the decay exon, or the poison exon as they call it, and turn it off. And so as a result, you get all of the good stuff made, and you also get all of the bad stuff made. And that's okay, because the bad stuff doesn't work anyway, but you've got 100% of good stuff now, and it replaces what was lost and causes Dravet. They've shown it works in mice. We know that it can reduce, when they use it in mice, that they can restore the amount of SCN1A that would be in an otherwise normal, healthy mouse. So the approach appears to work. And what's encouraging is when they looked at mice with Dravet syndrome, they tend to die from sudden unexpected death within the first couple weeks of life. And what they showed is when they used this ASO therapy, that basically almost all of the mice survived versus the ones that didn't get the treatment, who died of SUDEP, as is typically seen. So this trial is underway now. It's called the Monarch Trial. We're studying that for patients with Dravet syndrome in the first in-human version. There's also going to be a viral vector therapy for Dravet syndrome, where they take a virus and attach to it genetic material that does similar things to increase the amounts of good SCN1A. And that trial is expected to start hopefully at the beginning of next year. So another exciting, very specific therapy. And what's exciting about these things is that these are treatments that are specific to the genetic problem. And so maybe they're going to fix more than just seizures. Maybe seizures get better, but so does development. And so does the abnormal gait of Dravet, and the sleep problems of Dravet, and the behavior problems of Dravet. So that's why we're so excited about these. And if this works, this is just one example of what can work. Then we can look at other genetic abnormalities and hopefully fix those conditions as well. Last two slides, a couple other exciting things just to keep your eyes peeled for. There is a drug for SCN8A that is coming up in the future. So this drug specifically targets the sodium channel that is abnormal in that condition. So if you have SCN8A encephalopathy, keep your eyes peeled for that trial. And finally, important to folks with LGS, there are new rescue medicines out there and available. Nasolam and Valtoco are both nasal versions of rescue medications that are now available and approved by the FDA. And there was a wonderful webinar, the link is right there, provided by your LGS Foundation, that covers many of these rescue medicines. So the future is bright. There are a lot of options out there for LGS, and even more coming, and it's getting more and more and more specific as time goes on. So understanding your etiology is incredibly important if you don't already. Also important is November is right around the corner, which is Epilepsy Awareness Month, and we raise epilepsy awareness on the daily around here. So I hope everyone is prepared and eager to do their job in the coming months. And that is that. Thank you.